Alright, welcome to this class. In this class, we will talk about pure anti-estrogens. Pure anti-estrogens. Now, unlike SEMs, in the previous video we discussed SEM that they sometimes act as agonists in certain tissues and act as antagonists in other tissues. This one we are discussing today, they are pure anti-estrogen, meaning they are completely antagonists. So they 100% block the receptor. Okay, they 100% block the receptor and they have what? Zero agonist activity. The first one we will discuss is fulvestrant. Fulvestrant. Okay, now this fulvestrant is actually a modified estrogen derivative, particularly a modified estradiol derivatives. Its function is to block both the alpha estrogen receptor and the beta estrogen receptor. Apart from that, it also causes complete degradation of the receptor. Apart from blocking the receptor, it can induce the receptor to be destroyed completely. So it is also called selective estrogen receptor downregulator. Okay, so for short, it is also referred to as SED. Okay, so fulvestrant is a what? It's a SED. It's a modified estradiol drug that blocks both alpha and beta estrogen receptor, then also cause proteolytic degradation of the receptor. So you can see that apart from blocking it, it destroys the receptor completely. So how do we give it in terms of its pharmacokinetic? It is given once a month, okay, as an intramuscular depot injection. You give it to the patient once a month, and again, around day 7, it will approach its peak levels and is excreted in the feces. 90% of the drug is excreted in the feces. Then what do we use it clinically for? It is used for tamoxifen resistant breast cancer. You know tamoxifen is a what? It's a SEM, okay? Selective estrogen receptor modulators. This one causes complete degradation of the receptor, complete blockage of the receptor. So in cases whereby there is a tamoxifen resistance, so the patient is not responding to tamoxifen, you can give what? Fulvestrant, because fulvestrant will block the receptor and also destroy the receptor. So that is the clinical use of fulvestrant for tamoxifen resistant breast cancer. Okay, tamoxifen resistant breast cancer. What will be the side effect? Of course, the side effect will be the effect of you blocking estrogen receptor. You know, estrogen normally helps to like prevent hot flushes and the rest. Also help to ensure your bone is strong. So if you are causing estrogen effect to be blocked, you will expect hot flushes, you will expect back pain. This back pain could be coming from the bones and the rest due to bone resorption that is occurring. Okay, other minor side effects include stomach upset, headache. These are general side effects, but it's important for you to take note of the fact that there is no risk of endometrial CA for a patient taking fulvestrant. There is no risk for endometrial CA because the reason why there was risk for endometrial CA with tamoxifen was because tamoxifen act as an antagonist in the breast while acting as an agonist in the endometrium. Okay, so that was the reason why tamoxifen has the risk of breast CA. But fulvestrant blocks all the receptor everywhere and even causes destruction of that receptor. Okay, so take note of that. The next one on our list here is clomiphene. It's also called clomiphene citrate. So called what? Clomiphene citrate. Now, what is the main use of clomiphene? The main use of clomiphene is to induce ovulation. So it is used in women with PCOS. Women with PCOS that has an ovulatory cycle. So probably they are seeing their period, but they are not ovulating. Okay, they are not ovulating at day 14. So we give them clomiphene citrate to induce or trigger ovulation. Now, how will clomiphene do this one? Clomiphene blocks the estrogen receptor in the hypothalamus. You know, it's an antagonist, right? You know, we're discussing antagonists. Fulvestrant, clomiphene, they are all antagonists. So it will block the estrogen receptor, particularly at the hypothalamus and the pituitary gland. So now that normal feedback that normally goes back to the hypothalamus and the pituitary gland will not be allowed to continue, because if clomiphene is blocking it, estrogen will not have any place to like bind to and signal the hypothalamus that, oh, this estrogen is already enough, you should stop producing FSH and LH. So clomiphene will block that receptor, so estrogen can no longer do feedback inhibition again. So by so doing, the hypothalamus will think that, oh, estrogen level is low, let me produce more FSH and LH. So that's what will occur. So you can see that the brain can no longer what is no longer sensitive to what estrogen. So it assumes that estrogen level is what is zero or is already reduced in the body. So it will turn off the negative what feedback mechanism and start dumping LH and what FSH. So when you have high FSH and LH, it's going to stimulate the ovary. Then from there, ovulation will start and everything will start occurring. Now, again, like I said at the start, the clinical use of clomiphene is in the treatment of anovulatory what infertility in women with intact hypothalamic pituitary ovarian axis. So the whole axis system from the hypothalamus to the pituitary to the ovary must be intact. Okay, that is in those women that we give clomiphene citrate. Example of such is women with PCOS. Now, what do you think will be the side effect of clomiphene? Due to excess stimulation of the ovary by the FSH and LH that is being produced by the pituitary, is going to cause ovarian enlargement. The ovary will enlarge, okay, and it's also going to cause, and if the ovary enlarge to a certain point, it can bleed, it can cause internal bleeding. You get. Then again, we have what we call ovarian hyperstimulation syndrome. Then most importantly, multiple pregnancy, because the woman will be ovulating, you can ovulate twice in a cycle. You get. So this one will lead to what? This one will lead to twin pregnancy, triplet. Okay, so that is it. Take note of that. Then again, as a side effect, blood vision. Then also, if you give this clomiphene for more than 12 cycles, there's risk of ovarian cancer. Just take note of that. But the major risk factor we are scared of is this multiple gestation or multiple pregnancy. Very, very important. Then also take note of ovarian enlargement, which could lead to rupture, because if the ovaries are getting bigger and the blood supply is not able to meet up with the demand, the blood will rupture. Okay, the blood vessel will rupture. Then again, another form of inhibition we can do is to inhibit the enzyme that synthesizes what estrogen. That is called what aromatase. So aromatase enzyme can be inhibited. So instead of blocking the receptor, we give this aromatase inhibitor to inhibit the synthesis of what estrogen. So, and there are two chemical class of this aromatase inhibitor. There are some that have the steroid nucleus. There are some that do not have the steroid nucleus. So there are two types: type 1 inhibition and type 2 inhibition. Type 1 inhibition is the same thing as the one that has the steroid nucleus. So a good example of type 1 inhibition remains azemestine, formestine. So you can see they are ending with what? Estine. You can see it. So azemestine, formestine. Okay, so take note of that. Those are all these ones, they do what we call suicide inhibition. They irreversibly inhibit the enzyme. While for the non-steroidal one, they reversibly. So the difference between the steroidal and the non-steroidal one is that while the steroidal ones are irreversible, meaning suicide inhibition, this non-steroidal aromatase inhibitor are reversible. A good example is what? Letrozole, anastrozole, and vorozole. So in this one, you can see they are ending with zole or ozole. You get the hand. So, and again, they are not the only drug that end with zolo. Other drugs still end with zole. For example, your antifungal drug, ketoconazole, and the rest. You get. So take note of that. Just learn them: letrozole, anastrozole, vorozole. Okay, so they reversibly inhibit the aromatase enzyme. Now, what is the advantage of this drug over tamoxifen? What do you think is the advantage of this drug over tamoxifen? Tamoxifen is mainly used for premenopausal women, menopausal women. But for postmenopausal women, we give them some of this what is it called now? This aromatase inhibitor, because in postmenopausal women, the main route for the synthesis of the estrogen, is through the adrenal pathway, through the adrenal hormones that are being converted to estrogen. Okay, so in that case now we need to inhibit the enzyme. That's why these aromatase inhibitor, they are more effective in preventing breast in what, in postmenopausal women. Postmenopausal women are no longer producing their estrogen from the ovary again. Rather, they are using from androgens and from adrenal corticoid hormone. Okay, so we tend to like inhibit the synthesis of those hormones. That's why we give them aromatase inhibitor like letrozole. Then again, there's zero risk of endometrial cancer because we are not stimulating any hormone or any receptor. We're not stimulating any receptor in the endometrium. We're not inhibiting anything. What we're inhibiting is just the synthesis. Okay. Then there's also zero risk of deep vein thrombosis. Zero risk of what? Deep vein thrombosis. You know, estrogen tends to cause thrombosis. Okay, so there's zero risk of deep vein thrombosis. What do you think are the disadvantage? If you cut estrogen supply completely, again, you expect hot flushes. And not just hot flushes, there will be osteoporosis. So that's why whenever you are giving this drug, you are advised to give them together with bisphosphonate. You are advised to give them together with what? With bisphosphonate for the bone osteoporosis that is occurring. So that is everything for this video. Thank you. In this video, I believe we've been able to talk about the estrogen antagonists. We talked about the one that acts on the receptor. We also talk about the one that acts by inhibiting what? Enzyme inhibition. Okay. For the one that acts on the receptor, we talked about fulvestrant. Then we also talk about clomiphene. I said fulvestrant is given for tamoxifen resistant breast cancer, while clomiphene is given for ovulation, to induce ovulation, while these ones are majorly for postmenopausal women. Here we have letrozole. You get, so this is the major one there, letrozole. And we said there are two types. We have the steroidal one and the non-steroidal one. We said the steroidal one, they irreversibly inhibit, they are suicide inhibition, and this one are what? The non-steroidal are reversible. So thank you very much for this video. I hope you like this video, so like and subscribe. Thank you.